Good evening, all. I hope everyone is fine and doing well. I, Dr. Dushyant, on behalf of About Primary Care General Medicine Division, welcome you all for this academic feast virtually. We at Abbott believe that continuous medical education and knowledge sharing would surely improve the patient outcome. And to continue our endeavor to achieve it, we have planned this very important and pertinent webinar on a very relevant subject, that is acute vertigo. As we all know that dizziness is basically one of the most common symptoms with which patients lands up to outpatient department and emergency room to the physicians, and this accounts to a tune of 15 to 20% of cases globally. Out of this 15 to 20% of cases of dizziness, close to 54% of cases are of true vertigo, which is because of either vestibular pathology or of central pathology. And this particular acute vertigo has a significant impact on the quality of life of patients. And if the patient is not managed and diagnosed correctly, it will definitely go into a chronic stage and in chronicity. So, this is the very relevant topic for the day. And I hope that I hope that most of you attending it would surely get some fruitful learning out of this particular session. And I would also urge you that ask your questions, your queries by typing in the chat box and send it to us. We will try to accommodate as many questions as the time permits, and the expert of the day would definitely going to address it to your satisfaction. So the today's expert for the talk is none other than Dr. Mohan Kameswaran, sir. Sir is Director and Chief Consultant at Madras ENT Research Foundation, Chennai. He has been the recipient of Padam Shri and Dr. B.C. Roy National Awards, is being a visiting faculty to Professor H. Hill University, UK, and University of Pennsylvania, USA. Sir is being a regional secretary for Asia and International Federation of Otorhinolaryngological Societies, has been invited at multiple forums as a speaker to speak, and these are the societies like WHO, Royal Society of Medicine, and American Academy of Otorhinolaryngology. Sir is a hardcore researcher, has been training lot of postgraduate and DNB students at his center, and has more than 200 publications in major international and national journals, and has contributed over 39 chapters in various ENT or neurootology textbooks. Sir is also a very humble and generous personality, is known for his social commitments, and conducted over 700 free camps in various parts of the country. So, Sir would be going to talk on management of acute vertigo, and this would be followed up by a question and answer session. What Sir is going to cover today, he will be having a case-based approach. He will be going to show you cases, and post that he will throw some more light on how to differentiate peripheral vertigo from a central vertigo, and how to manage a case of acute vertigo. What are the treatment options, the pharmacotherapeutic options, the non-pharmacotherapeutic options. So with this, without a further ado, I would like to welcome the speaker of the day, Dr. Mohan Kameswaran, sir, to enlighten the audience. And with this, sir, over to you to take the proceeding ahead, sir. Over to you, sir.
Thank you, Dr. Dushyant. And my thanks at the very outset to Abbott Medical for inviting me over for this talk. I am going to be sharing my thoughts with you today on management of acute vertigo. So, I would first of all like to share with you some real life experiences. In the sense, in the last few months, I mean, since the lockdown started in March, I was just looking back at those cases which we have actually seen, cases of acute vertigo, and I've chosen about three or four samples to sort of introduce the topic, and also give a real experience about how these patients are presented and how we manage them. Now, the first patient was a lady, a 50-year-old lady, a gynecologist by profession. Now she had, actually got up from bed with severe vertigo in the morning, early in the morning. When she got up from bed, she found the whole room spinning, and she ended up vomiting, and she was absolutely in panic. But she thought she was actually getting she was going to die. She had getting an MI or whatever, but she had no pain. But it was a very frightening experience for her. So she was immediately rushed to a nearby hospital, where she was given an injection of prochlorperazine, 12.5 grams, in a nearby multi-specialty hospital. She settled down, and then immediately they did a full evaluation for her. The only remarkable finding was her BP was very high at the time, 180 by 90. Although she's never had hypertension, she checked her BP on a few occasions before. It's always been around 120 by 70 or so. On this occasion, it was very high. It was 180 by 90. ECG also was unremarkable. It was more or less normal. Some very minimal changes, which they thought was not significant. She was advised an echo and a CT coronary anyway, because the doctors didn't want to take a chance, and she was a gynecologist, very well-known gynecologist. But the vertigo settled, and in about 4 hours' time, she was completely free. So she discharged herself, and then she came for an ENT opinion. Now, ENT examination was absolutely normal. There was nothing wrong with her ears. Eardrum was normal, no nystagmus. Hearing was also normal. Neurological examination, which was done in the outpatient, was also completely normal. All her higher function was normal. Cerebellar function was normal. Cranial nerves were normal. Spinothalamic and pyramidal tracts were normal. BP was at the time normal also. It was only 120 by 124 by 70. X-ray cervical spines had been done in the hospital before where she went, and they showed some very diffuse osteoarthritic changes. So we then did, based on the history, we suspected a positional vertigo. So we did a Dix-Hallpike test, which of course I'll be showing you later. It was very strongly positive on the right side. Immediately she had a recurrence or recapitulation of her vertigo, and therefore that clinched the diagnosis of a benign paroxysmal positional vertigo. So immediately we corrected it, and Epley's maneuver was done, and instantly she felt better. She got up and she said, "I'm feeling absolutely fine." And then she went back home. She was discharged. I mean, from the outpatient, she wasn't admitted at all. She was sent home. In fact, we hardly gave her any medication. We just told her to take prochlorperazine or Stemetil tablet, SOS. And she has been asymptomatic. In fact, she went back the day, and she ended up doing surgery, cesareans, and conducting labors from that day onward. So that's a first scenario of a person with positional vertigo who had very violent vertigo in the morning, had to be rushed to an ER, had injection prochlorperazine, recovered after that. The acute vertigo settled down, but then she came and got herself a Nepalese maneuver done, corrected, and then she went back to normal. The second scenario was a 48-year-old gentleman. He was a nuclear scientist working in the atomic energy plant near Chennai, is known as Kalpakkam. And he also, suddenly got up with a severe vertigo, and this vertigo lasted for about 4 hours and was accompanied by violent vomiting. In fact, she had about 4 or 5 episodes of vomiting, and there was a severe tinnitus in the left ear and a feeling of pressure and blockage in the left ear. So he went to his own hospital. They have a very good hospital in their atomic energy plant, which is it's a mini city actually, and a very nice hospital. So very well equipped. So he was rushed to the ER there. He was administered injection prochlorperazine, Stemetil, and then was given a bed to lie down in the ER itself. There they did an ECG and echo. It was normal. Then he then went and had an MRI in the hospital, and an MR angiogram of the brain, an MRI of the brain, and an MR angiogram, which is normal. The cervical spine MRI showed significant posterior osteophytes at C4, 5, 6 level, and the provisional diagnosis of cervical spondylosis with vertebrobasilar insufficiency was made. So this patient was then referred for a ENT opinion. And based on the history and clinical examination, because this patient had hearing loss on 1 year in an audiological finding. He had a nystagmus, peripheral nystagmus, which we'll talk about later. And he underwent investigations, including audiometry and vestibular function tests, which showed clearly that there was a vestibular dysfunction on the left side, what we call a canal paresis on the left side. And therefore, a diagnosis of left Meniere's disease was made. Patient was given prochlorperazine tablet twice daily for 3 days till the acute vertigo settled down. He was asked to continue a salt-restricted diet and was on beta-histine 48 milligrams a day in divided doses and diuretics for a period of 4 weeks. His vertigo settled completely. He was advised to be on a low-salt diet, which he followed quite strictly. The tinnitus is still present. Hearing loss also, he had a moderate hearing loss, about 30 decibel low frequency hearing loss in that ear, left ear, which is also present. But that apart, the vertigo had completely settled down. The patient has been told to have a periodic follow up. The third clinical scenario is a 28-year-old software engineer with a history of neck pain and occipital pain and sudden, light-headed feeling, and rotatory vertigo lasted for about 15 minutes, associated with nausea. Then there was no vomiting at that time, but he felt quite nauseous. There's been past history of episodic headaches for him, which he used to get quite severely, and there's a history of migraine in the family. Both his elder brother as well as his mother were known migraine sufferers. No otological symptoms. He had no feeling of ear block, no tinnitus. Hearing was absolutely normal both sides clinically. And so patient was given again prochlorperazine injection to stop the vertigo and the feeling of nausea. He felt better after about 15-20 minutes. So then he came for an ENT opinion. His audiometry was normal, vestibular function test was normal. He had a CT of temporal bone done elsewhere, and then MRI and brain was also normal. So, in short, this gentleman had a history of neck pain and occipital pain, accompanied by severe vertigo, the strong family history of migraine, and all the vestibular tests, audiological tests, everything was normal. So, this gave us the diagnosis of a migrainous vertigo or a vestibular migraine. The management was, of course, he had prochlorperazine tablets, SOS. Whenever he had nausea, he was asked to take it, vertigo or nausea. And he was placed on prophylaxis for migraine. He was on beta blockers and flunarizine for a period of about 3 months, after which he was completely fine and was taken out. He was counseled regarding lifestyle modifications because he was quite an erratic person. He had hardly didn't sleep well. He had late nights and all things. And so we counseled him about lifestyle modification. Is further no further episodes of headache or vertigo since then, and he's quite happy. The last scenario is quite a dire scenario. Is a 68-year-old retired school teacher who's a diabetic. He was taken to ER with a severe vertigo and vomiting. Again, he was given injection prochlorperazine or Stemetil in another hospital, and he was then they asked for an opinion. The gentleman had some ominous findings. He had a nystagmus, which was sometimes vertical and sometimes direction changing. His hearing was more or less normal. He was in severe distress. Cervical spine X-ray again showed severe osteoarthrosis. And there is a history of recent upper respiratory infection in two family members also, who both had severe viral infections, not COVID, but they had developed some viral infections in two of his family members. The bedside test, we did what's known as a Hinds plus test, which we'll talk about later. And this suggested possibility of a central vertigo. Now, then differential diagnosis, we had two options. Because his hearing was completely normal. So the option one was vestibular neuronitis, and the other important second option was brainstem stroke. So we then persuaded him to take an MRI urgently, and this showed an acute brainstem infarct involving the posterior inferior cerebral artery territory, or what is known as a lateral medullary syndrome. So we shifted him to a neuro intensive care facility But unfortunately, the patient did not recover. He deteriorated gradually, and 8 days later, he died from multiple brainstem infarcts. So you have had this entire, these four scenarios. All of them, the one common feature was that they all presented with acute vertigo. But then you can see that the spectrum has been quite different. In one, you had a positional vertigo in a doctor where they hardly, although the symptoms were very violent and she was very anxious about it, was the cause of hypertension in her. But the moment she was corrected, had an epidural, she was absolutely fine. And the same day, she could go and conduct a cesarean section, and she was absolutely fine. The other extreme is this retired teacher who came with severe vertigo, not very violent, but severe vertigo, and had vomiting also. Had again a prochlorperazine, which seemed to help him temporarily, but this gentleman had a brainstem stroke and then went in to die 8 days later. So acute vertigo, can be a symptom of a myriad of conditions, and we have to, really distinguish between them to know what we're dealing with. There are many patients who will come and tell you that, I had a problem. I was seen in a hospital. They, did all the tests, and then they told me my diagnosis was vertigo. Now, that's the first thing we have to talk about, because vertigo is not a diagnosis. Vertigo is a symptom. It's as ludicrous as saying my diagnosis was headache. So supposing a patient comes to me and tells me I've got headache, and then I do all sorts of scans and things, and then I tell him your diagnosis is cephalalgia, which is again Latin for headache. It doesn't really make sense. So vertigo is not a diagnosis. Vertigo is a symptom. That's the first thing, the lesson that we have to keep in mind. And also, vertigo is multidisciplinary. It's not the purview of ENT or neuro or ortho or cardio or something. Vertigo is a multidisciplinary symptom, because it can be a symptom of a variety of conditions which span across several specialties. So somebody has to have really, a working knowledge of more or less all the conditions which can cause vertigo, which is what we'll be aiming to do today. So the etiology of vertigo is everything. So when a patient comes and tells me I'm feeling dizzy and I'm feeling, I'm having severe feeling of rotation and I'm having vertigo, my first question should be, what is the cause of it? What is the etiology behind it? And only then can I work out a strategy for managing the vertigo. So without knowing the etiology, you cannot manage vertigo. You can give them medication like prochlorperazine to settle the vertigo, acute vertigo, irrespective of the cause. But that is symptomatic management. That is not the management of vertigo. The vertigo can only be managed once you have the diagnosis. So this has to be very, very clearly ingrained in us. And no matter what the cause of vertigo, whether it is a positional vertigo, whether it is a brainstem infarct, whether it is Meniere's disease, whatever the cause, an acute vertigo always causes anxiety in a patient. You will always, these patients have, they have this terrible apprehension that something seriously is going wrong with them and that they're going to be dying. That is their feeling inside them. So they all have anxiety and apprehension, and they will all have associated vegetative symptoms, so like nausea and vomiting. So vomiting in vertigo only tells you that the vertigo is severe. That's all. That's the only significance of it. So if a vertigo is sufficiently severe, no matter what the cause, this person will have vomiting. So vegetative associated vegetative symptoms like nausea and vomiting are an inherent part of any acute vertiginous episode. And labyrinthine sedatives, like prochlorperazine, cinnarizine, whatever, is very effective in relieving the peripheral vertigo and associated symptoms like vomiting and anxiety. Particularly prochlorperazine, is also an anxiolytic drug and stops the vomiting also. So it's quite a effective drug in acute vertigo. But remember, it is a symptomatic management. So then, what is actually the burden of acute vertigo? Let us look at the toll of the dizziness. Now, dizziness is a chief complaint in at least 5% of walk-in clinic visits. and the third most common major medical symptom reported in general medical clinics. So it's quite a common problem. We really have to keep that. And in an acute care setting, patients coming with dizziness, complaint of dizziness, accounts for about approximately 4% of all emergency department visits. So it's really quite a common problem, and everyone is going to be seeing one sooner or later. Among the elderly, it is quite high. It can be even high as 60%. And at least 10% of those over the age of 65 will be affected by vertigo at some point of time. And it ranges around 20 to 35% in a general, if you take a crowd of people at a point of time. Women are disproportionately affected at all ages. Now, the other problem of dizziness is the risk of fall, especially in the elderly. So, when you have a dizziness, particularly, let's say they're in a vulnerable situation, like they're having a bath, for example, in the toilet, then suddenly the risk of falling down because of the dizziness or the vertigo, and this may lead to problems like a fracture, or which is even more serious. I mean, that can be, the vertigo may be transient and it may settle down, but this effect of the vertigo, like a fall, for example, may linger on, and they may end up with serious issues, even disability or death in some people. It definitely decreases the quality of life and the ability of a person to function. So that's one of the very serious issues in the elderly. Many of them are already lonely. They are staying alone with caretakers and so on, because the children are somewhere in the world, and for them they lose the self confidence. They lose their ability to perform and function on their own, and certainly this deals a severe blow to their quality of life and lead on to secondary depressions and anxiety and so on. So basically, vertigo may be peripheral or central. And the vast majority, thankfully, are peripheral. Well, more than 90% of patients coming with vertigo have peripheral vertigo. Only about 10% have central vertigo. So this is something which has to be kept in our mind, because the tendency for everybody to, when a person comes with vertigo, is say, look, go and get an MRI done, get a neurology opinion and so on. But remember, only 10% of patients have actually a neurological problem causing vertigo. More than 90% have a peripheral lesion. So this is the first thought process that should be in our mind. Majority of them, and I said thankfully they are in peripheral, simply because the peripheral disorders, even though they cause very violent vertigo and cause a severe erosion of self-confidence, they are also much more easily managed, and they have much less morbidity compared to the central vestibular disorders. So peripheral disorders are frightening. They're like a barking dog. They don't bite. Whereas the central disorders are the dogs which are biting dogs. They may not bark so much. So always, it's far better to have a peripheral vestibular disorder if you had a choice. So we have to distinguish in an acute vertigo, we have to distinguish a peripheral cause from a central cause. And a peripheral cause, of course, we'll go into it a little more detail, could be due to vestibular pathology. It could be due to benign paroxysmal positional vertigo, Meniere's disease, a variety of conditions. Central cause, more often than not, may be migraine or a stroke, or maybe a posterior fossa demyelinating disorder, or a mass which is suddenly given rise to symptoms. And you also have to rule out systemic inflammatory diseases, diabetes, hypertension, cardiac failure, side effects of certain medication, and so on. So let's look at the peripheral vertigo, acute peripheral vertigo. Acute peripheral vertigo is a short-lived episode of vertigo, acute and unprecipitated, and it's associated invariably with nausea and vomiting if it is severe, and it's commonly associated with otological symptoms, although not necessarily. So most peripheral vertigos will have some otological symptoms like a feeling of tinnitus or ear blockage or something. Of course, the notable exception, of course, is the benign paroxysmal positional vertigo, where the patient will not have any otological symptom but has a peripheral vertigo. Central vertigo, on the other hand, is much more insidious, and it is protracted. Whereas an acute peripheral vertigo is episodic, it comes in episodes. Central vertigo is much more insidious and protracted, and often associated with gait problems, unsteadiness, stumbling, a tendency to fall, and so on. And the four Ds, are often the symptoms of brainstem and cerebellar issues. These are diplopia, dysphagia, dysarthria, and dysmetria, which is really the lower limb, ataxia. So basically, you have the four Ds. Remember the four Ds: diplopia, or double vision, dysphagia or difficulty in swallowing, dysarthria or difficulty in articulating and talking, and dysmetria, which is a lower limb ataxia or incoordination. So, if you want to differentiate between central and peripheral vertigo, remember central vertigo is only 10%, peripheral vertigo is 90%. Central vertigo is bad news, peripheral vertigo is definitely better news. So, let us look at each symptom. The patient, when he complains of imbalance, central vertigo patient will always complain about a feeling of severe imbalance. I'm going to fall. I'm not comfortable at all. I'm going to fall. Whereas imbalance is not a major feature in peripheral vertigo patients. It's is usually mild or moderate, and it's usually episodic. In between the attacks, they're quite okay. Neurological symptoms are frequent in central vertigo, as would be expected, but rare in peripheral vertigo. And then the nystagmus. Always look at the eye, and look at the nystagmus. In a peripheral vertigo, nystagmus is always unidirectional. So it will never change direction. It will, no matter which way the patient looks, say, look straight or right or left, it's always one side only. Whereas in a central vertigo, nystagmus, one of the important hallmarks of the nystagmus is that it is direction changing. So if he looks to the left, he may be having a left-sided nystagmus. If he's looking to the right, he may have a right-sided nystagmus. And the other very important thing is in a patient who's got a peripheral vertigo, the nystagmus, is quite bad. He's having dizziness. The tendency of the patient is to close the eyes immediately, but in fact it exactly has the opposite effect. Now if the patient who's having vertigo and having nystagmus closes his eyes, the vertigo becomes worse. So you have to instruct him, no, 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 don't close your eyes, keep your eyes open and fix on a particular point. So start looking at some particular point, maybe on the wall or a picture or something. So if he focuses his eyes and fixates his eye on a particular object, the nystagmus comes down, the vertigo also comes down. So in a peripheral vertigo, it is always unidirectional, the nystagmus, and the nystagmus will become less on visual fixation. By contrast, in a central vertigo, the nystagmus may be direction changing. It may be left, right, with left side on looking to the left and right on looking to the right, but it will not change with visual fixation. This is something to be remembered in our mind. It's a hallmark of central vertigo, and it is bad news. Hearing loss is almost always a cardinal feature of peripheral vertigo. So when the ear is affected, the inner ear labyrinth is affected, invariably hearing loss will accompany. Remember, the inner ear has two functions. We always tend to forget that. One ear for one function, of course, which you all remember is hearing, but even more important than hearing is our balance. And the inner ear does both functions very efficiently from the time we are born till the time we are enter in our grave. So it is a constant function of the inner ear to endeavor to do both hearing as well as the balance. And therefore, certainly hearing loss is an accompaniment. If it is present, strongly suggest to you that the problem is in the end organ, which in this case is the inner ear. And it's rare in central vertigo unless the central lesion is also affecting the brainstem, the cochlear nucleus in the brainstem, which is the area of hearing. Nausea is always very severe nausea and vomiting in peripheral vertigo. So, if a patient is throwing up violently with vertigo, chances are more than even that it is a peripheral vertigo. You may have nausea and you may have vomiting also in central vertigo, but it is much less commonly seen. So it is variable, and sometimes it may not even be a feature of central vertigo. And recovery by central compensation is inevitably happening in peripheral vertigo. So we always talk about the so-called cerebellar clamp. Although it is not really an accurate term, we always say cerebellar clamp, which really is a loose term, that somebody who has a peripheral vertigo, no matter what, even if you cut the vestibular nerve, or you destroy the labyrinth, in that patient, vertigo will not last for more than 3 or 4 weeks. It will be back to normal. It'll be back, because this is because the brainstem and the cerebellum will act to control the vertigo. It will suppress the vertigo, and the opposite labyrinth will compensate. So compensatory mechanisms are very, very good and efficient in peripheral vertigo, but they're very, very slow in central vertigo. So this is a very important takeaway point between central and peripheral vertigo. To summarize, peripheral vertigo is much more common. It's accompanied by severe. Usually, it's accompanied by severe vertigo and vomiting, and nystagmus is always unidirectional, and it is reduced by visual fixation. And hearing loss is often seen in peripheral vertigo, but not so much in central vertigo. And the compensation is also much better in peripheral vertigo. So typically, if you have a labyrinthine lesion, let me say that a patient comes to me and I operate on his labyrinth inner ear, and then cause damage to the inner ear. Now, then this patient postoperatively will have a severe vertigo. He'll have nausea, vomiting, and he'll have a horizontal nystagmus, as we already said, and it will reduce with visual fixation. Now, next 2 or 3 days, the nystagmus will settle down. Now, supposing I've operated on a patient with a big cholesteatoma, which is destroying the labyrinth, and so in the process, I also I have to destroy the labyrinth. This patient will have violent vertigo, but second day, third day, start getting up, he'll be walking. He'll still have a bit of vertigo, but he'll feel a lot better. And so, within a few days, the compensatory mechanisms have kicked in. And if the symptoms last very long time and it's not settling down, then the chances are then you're not dealing with a peripheral vertigo at all. You're dealing with a central vertigo. So, what are the common causes of acute vertigo? In not only not learning but it's in any practice. Let's say in general practice also. Basically, the commonest cause of acute vertigo is benign paroxysmal positional vertigo. It's by far the most common problem that will present to you. The next common cause, although it's not recognized very much, is migrainous vertigo. That is, patients with migraine presenting with vertigo. Meniere's disease is perhaps the third commonest cause. Labyrinthitis, chronic otitis media with labyrinthitis, or viral labyrinthitis. This is the next common cause. And finally, vestibular neuronitis. Although every book will talk about it and everyone will talk about it in every classification, it's not common at all. It may seem to happen, especially in viral, epidemics, and like the one we're having now, viral pandemics. Fortunately, in this COVID pandemic, we haven't seen too many cases of vestibular neuronitis. We have seen a lot of other ENT complications, such as invasive fungal sinusitis. We have seen sudden hearing loss and so on. But surprisingly, vestibular neuronitis is not a very common problem in pandemics like COVID pandemic. But vestibular neuronitis is quite common in the West, in the Caucasian population. When I was working in UK, it used to be quite a common thing. I used to see one a week or so. But now, coming in India, practicing in India, even though we have a very busy vestibular clinic, we very, very rarely see vestibular neuronitis. So vestibular neuronitis is not a very common problem. Acute central vertigo is really bad news. Somebody who has a vertigo which is acute and it is central, you really need urgent neurological assessment and management. So, in short, to establish the cause of vertigo is absolutely everything. It's very, very crucial. And a good history taking and clinical examination is very important. Bedside examination will give you a lot of information, as we shall see in the subsequent slides. Investigative modalities also are helpful. They facilitate diagnosis, but the clinical assessment, history taking and clinical assessment, by far gives you much more information than even the most sophisticated investigative modalities that you can think of. So history taking is very important. So let's look at the questions. You have to ask the right questions, because this patient is no mood to be answering you. He's sick, he's unwell, his world is spinning. He feels like throwing up. He's feeling nausea. The last thing he wants is this young doctor sitting in front of him and asking a barrage of questions. But you have to take it out of his mouth. You have to explain to him that these are going to be very important in his management. The first question is it true vertigo? And what is true vertigo? You have to have a sense of relative movement or motion between the subject, the person, and his environment. So there has to be a sense of rotation or movement. It may not be only rotation, it may be up and down movement, it may be side to side rocking movement, but there has to be a sense of rotation or movement between the subject and his environment. And of course, is it central or peripheral? We already talked about it. We talked about what is peripheral vertigo, and generally ask about the time course. Is it a few seconds? I mean, like this man got up, this lady, we talked about the first case, the gynecologist. She just got up from bed. She had this vertigo, very, very severe vertigo, vomiting, few minutes. That's it. Or it lasting for a few hours, 3 hours, 4 hours, like the gentleman who was a nuclear scientist from Kalpakkam. Now he had a 4 hour attack, continuously vomiting and throwing up and vertigo with tinnitus and so on. That's many years. So the time scale or the time course gives you a lot of information, and any relieving factors or precipitating factors. That the head motion indicate any aggravation of symptoms. This is fairly typical in benign paroxysmal position vertigo. I used to tell you, if I bend down, it becomes more. If I look up, it becomes more. If I rapidly turn to my left or right, I get it. So that's fairly typical in benign paroxysmal position. Is there an associated otological symptom? Tinnitus, hearing loss, oral fullness, they're all indicative of a peripheral cause, and there's a problem is somewhere in the inner ear. The exception, as I said, is benign paroxysmal positional vertigo, where there's no oral symptom at all. And is these symptoms getting worse when the vertigo attack is starting? For example, in many years, classically, the oral blockage or fullness of the ear will go up, and then tinnitus will suddenly change its character. It will become more louder, or it may become roaring, and then they have this attack of vertigo. So much so, many patients will start recognizing that a pitch change in tinnitus is a forewarning. They'll get ready for the attack of vertigo to follow. So they can even get use it like an alarm for them to indicate that a vertigo is following very soon. And then, of course, any associated headache, previous head injuries, any neurological symptoms, and so on. So basically, the questioning is very, very important. You have to get a detailed history from these patients. Then the associated symptoms also, as coexistent other associated symptoms like otological symptoms, headaches, diplopia, dysarthria, all that we said about central vertigo. And then medical history, very important: diabetes, anemia, orthostatic hypotension, any particular drugs. Typically, notoriously, are they on alpha blockers? Elderly gentlemen who have prostate problems on alpha blockers, notorious for having orthostatic hypotension. Or so always get these histories. You see an elderly gentleman telling me, sir, whenever I get up, I get this unsteadiness, I'm going to fall. Now, that could be an indication of orthostatic hypotension. So if you ask him, are you on any, drugs for your prostate problem? And he says, yes, I'm on an alpha blocker, tamsulosin or something. And then you tell him, look, that could be the issue. So take your time. It doesn't mean you have to stop your medicines, but remember that when you change your position, you may have a transient vertigo. But if you do it slow and take your time, this will settle down, reassure him, and then he'll be fine. And finally, psychogenic, is there a psychogenic vertigo can be quite distressing in some patients. So clinical examination, first of all, otological examination. Is the eardrum normal? Is there any cholesteatoma? Is there any chronic otitis media? And then a neurootological evaluation, of course, check the hearing with a tuning fork if you can do that. And then neurological examination, particularly, look for nystagmus, look for, spontaneous nystagmus, then direction. You change I ask him to look left and right, see any gaze-induced nystagmus or a direction changing nystagmus, so, and then, of course, Romberg's and Unterberger's test. And all these are clinical examinations that you do. And if the patient is severely vertiginous and is in bed, actually, there are some very important bedside evaluations that you can do. Look quickly for cranial nerve function, including a gross assessment of the visual fields, pupils, and corneal sensation. And look for extraocular motor alignment, mobility. Is there a eye movement? Is it consensual? Both sides, are they coordinated? Check the facial sensation. motor and sensory function, gait, and balance testing if the patient is able to stand up. And positional testing is very, very helpful. So a patient comes with a history suggestive of a benign positional vertigo. A positional testing, or what we call the Dix-Hallpike maneuver, I'll be showing you videos later, is an extremely helpful test. A patient who's got a peripheral vertigo, which is significant, always do a head thrust test. So that is, you turn the head quickly. We'll show it to you in a video format, and that will help you to make a diagnosis of a peripheral vertigo. And then the very, very important test, which is known as a HINS plus test, which is HINS stands for head impulse, nystagmus, and then T is for test for skews. And then the plus, of course, is for checking the hearing with what is known as a finger rub test. So we'll have to tell you a little bit about this because it's very important. Everybody should be cognizant of these tests. These are all bedside tests that you can give you, and they give you a lot of information, believe it or not. The BP record, of course, of the patient, and check the carotids. Make sure that you can palpate the carotids on both sides and so on. So, what is this HINS plus test? When vertigo and nystagmus is continuous, it's not episodic. This patient is continuously having vertigo for a few hours, let's say 2 hours, 3 hours going on. Now, there's no, this is a situation where it could be a peripheral or a central lesion. Peripheral lesion, the first thing to rule out, of course, if it's many years, you've got a hearing loss and tinnitus is on. If it's not, there's no associated hearing loss, the hearing is normal, then the peripheral lesion which can cause that is a vestibular neuronitis. And whenever you think of vestibular neuronitis, also always think about a brainstem stroke. These are two almost like twins, and they have completely different prognosis. So vestibular neuronitis and brainstem stroke are two sides of a coin. They always present almost similarly, but they're completely different problems and they have different prognosis. So what are the tests which will help you to differentiate this peripheral from the central pathology? First of all, the head impulse. So this, I have a video for you. I'll show it to you. Gently rock the head from side to side and suddenly move it to the center, and look up for what is known as a catch-up saccade. That is, you're turning from one side to look, the eye is following, it's a bit lazy, and then you fix it on a point, and then the eye catches up and looks up at the center. So the eye is a bit lazy when compared to the movement of the head. So this is known as a head impulse test. And then, of course, nystagmus. Is it single directional, or is there a direction change in nystagmus, or is it a vertical nystagmus? And there's something called Alexander's law for peripheral nystagmus. We'll talk about it. And then the test of skew. Again, we'll show a small video for you to see. And then check the hearing by rubbing your fingers around near the ear of the patient. Just rub it like that and ask him whether he can hear the rubbing sound. So this is the regarding the slide regarding the nystagmus. Central nystagmus versus peripheral nystagmus. Now, this is the eye in the central position. On looking to the right, you can see that there is a right nystagmus. And then the patient is asked to follow your finger to the left, and lo and behold, there is a left beating nystagmus. In other words, direction changing nystagmus. Right side, you have a right beating nystagmus. He looks to the left, and he's got a left beating nystagmus. So this is almost diagnostic of a central lesion, of a central nystagmus. By contrast, a peripheral nystagmus. This gentleman has got a basically on look, he's got a left beating nystagmus. Now, looking on the right side, he's got this right nystagmus. He has got a left-sided lesion. So, looking on the right side, that is opposite side of the lesion, the nystagmus gets exaggerated. So, this is a grade 1 nystagmus. In other words, you are bringing the nystagmus out by asking him to look away from the side of the lesion. So, let us say he's got a left ear problem. The tendency for the eye is to move to the left, and the correction is quick component is coming to the center. It's a quick component which is obvious to us, but it is a slow component where the eye deviates to the side of the lesion, which is actually telling you the side of the lesion. So this gentleman has got a left ear pathology, but when he looks to the right, that's the opposite side, the nystagmus becomes very severe, noticeable, and that is a case 1 or grade 1. Grade 2 is even when he's looking straight, he still has nystagmus, which is right beating. So this is a person who's got a more severe nystagmus. And finally, grade 3 or the most severe nystagmus, even when he looks at the side of the lesion, he still has nystagmus. So the person who's got a grade 3 will also have a grade 2 and grade 1. That is, a person who's got a nystagmus which is on looking to the left will also have a nystagmus when he's looking straight and looking to the opposite side. And the person who's got a grade 2 will also have a nystagmus when he's looking to the right, but not when he's looking to the left. So basically, this is to tell us how the grading of the nystagmus, and this is known as the Alexander's law. So now let's look at the head impulse test. So the head is moved rapidly from side to side. So, and if the patient has a nystagmus, if he has a lesion, a vestibular lesion, you will have a corrective saccade. So basically, what will happen is the eye is, looking straight here. This person is perfectly fine, of course. He's one of our doctors who's just volunteered. But if she had a problem, then when she's turning from side coming to the center, you will find that the eye is then catching up with the eye. There's a gentle drift, and the eye will move from side and fix onto the center. In other words, there is a little lag between the head movement and the eye movement, and that tells you that there is a peripheral problem. It's a peripheral lesion. It's a peripheral nystagmus. Now, the other one is spontaneous nystagmus and gaze-induced nystagmus. So here, the person is asked to follow a finger, and if it is, if he's just looking normally at you and you have nystagmus, that is spontaneous nystagmus. But if you ask him to follow the finger to the right or to the left, and then you elicit nystagmus, that is a gaze-induced nystagmus. In a peripheral lesion, it is always unidirectional. In a central lesion, it will change the direction, as you already saw. This is a test for skew. It's a very important test. So you cover the eye and then uncover it rapidly and see whether there's a drift of the eye. So if a patient has a central lesion, if you cover and you uncover, the eye will move up. You will see the eye drifting up. Now that is a skew. Now that is typical of a brainstem lesion or a central lesion. And if it is present, it is a very, very important sign of a brainstem lesion, and you need to really take this very seriously. So test for skew, you cover the eye, and basically let's just show that again. Quickly cover the eye and then uncover it and see whether the eye is moving up or drifting up. And that is a test for skew. You have to do each eye independently, the left here and then the right separately. So each eye is covered and uncovered, and you uncover it, is the eye moving up? So if you have a positive HINS examination, it's very, very important because it's 100% sensitive and 96% specific for a central lesion. So this tells you without doubt this is a central lesion. In fact, it's even more reliable than an MRI in early situations. So an MRI may take time to partially present, but this is immediate. It tells you immediately. It even is more reliable than an MRI in very early stroke. So look at the comparison between the sensitivity of MRI and HINS exam. So definitely HINS examination or clinical exam is even more sensitive than an MRI. So, what are the bedside examinations? Summarize in a non or a central etiology. You have a direction changing or vertical nystagmus. You have a sustained non-fatiguing positional nystagmus, and then each eye can be having separate nystagmus. It's disjointed or disconjugated. Abnormal posture when seated, inability to stand, the patient is ready to fall, and there may be focal motor deficit. There may be the 4Ds I told you about: dysarthria, dysphagia, diplopia, dysmetria. Horner syndrome may be present. There's a sympathetic paresis of the pupil, and there's again a brainstem lesion. Loss of pain and temperature sensation on one side of the face and the cross sensation of the body. That is, in other words, if you have right side face pain and temperature sensation loss, and the left side body pain and temperature loss, and then it could be intractable hiccups and incoordination as if he is drunk. So let's look at the commonest cause of peripheral vertigo, which is benign paroxysmal positional vertigo. So questions you have to ask yourself is it BPPV? Is it peripheral or central? Which semicircular canal is involved, and what repositioning maneuver are we going to be doing? So, what are the hallmarks of benign paroxysmal positional vertigo? This is an important slide. So, you have a torsional or a linear rotatory nystagmus by provocative position with the affected ear down. We'll have a video of this to show you. Nystagmus has a small latency. It doesn't immediately occur. You have about a 5 second lag, and then the nystagmus appears. It's of a brief duration. It usually lasts for about 30 seconds, and then it settles down. It fatigues, and if you keep on doing it, and each subsequent attack, that the nystagmus becomes less and less prominent. And when you make the patient to sit up or reverse the position, the nystagmus also reverses. In a central positional nystagmus, there is no latency. It immediately comes and may last for a long time, not 30 seconds, maybe a minute or two. And there may be no association with the canal. There's no fatigability. Every time you do it, it keeps on happening at the same intensity. And it may be direction changing also. And nausea and vomiting may happen, but may not be associated with the severity of the nystagmus. And there may be other neurological signs. So let us look at the three canals: the posterior canal, anterior, horizontal. Posterior canal is the most common. 90% of benign paroxysmal positional vertigo is posterior canal nystagmus. And classically, you have an upbeating nystagmus. That is, your head is down, but the eye is moving towards the going up. It's going up always. And when you sit up, it becomes reversed. So this is the thing. So let us look at the most common BPPV. Let us forget about the lateral canal and the superior canal. The posterior canal is the most common cause of 94% of BPPV. So if you have a right posterior canal problem, when the patient lies with the head to the right and the head down, you provoke a nystagmus which is upbeating, and it is torsional. And if he sits up, then the whole thing becomes reversed. In the left, of course, it is the opposite. And this is elicited by what is known as a Dix-Hallpike test. So I'll show you a video of the Dix-Hallpike test.
For the Dix-Hallpike test, the patient's head is turned 45 degrees towards the side being tested, and the patient is rapidly brought down to the supine position with the head hanging 20 degrees below the horizontal. At the same time, the patient's eyes are observed for nystagmus for a period of 30 seconds.
Fine. So let me just replay that for again. It's very important. So everybody should be able to do a Dix-Hallpike test.
For the Dix-Hallpike test, the patient's head is turned 45 degrees towards the side being tested, and the patient is rapidly brought down to the supine position with the head hanging 20 degrees below the horizontal. At the same time, the patient's eyes are observed for nystagmus for a period of 30 seconds.
Great. So this is a Dix-Hallpike test. Can be done in any clinic. It's safe to do. You don't have to be worried at all, and you can definitely elicit positional nystagmus very clearly and diagnose benign paroxysmal positional vertigo by the single one test. Now, once you have diagnosed it, then of course you have to correct it, and this is done by many procedures. But the most common procedure, and I would request all of you to be aware of one procedure. And if there's one procedure you have to know, it is a Epley's maneuver.
The initial part of the Epley's maneuver is the same as Dix-Hallpike maneuver. The patient's head turned 45 degrees towards the affected side, and patient brought to the supine position with the head hanging 20 degrees. The patient's eyes are observed for nystagmus, and we wait for the nystagmus to stop. After stopping of the nystagmus, we wait for a further 30 seconds, and the patient's head is turned 90 degrees towards the opposite side. We again observe for nystagmus and wait for the nystagmus to stop, after which the patient's head is turned a further 90 degrees towards the unaffected side along with the body of the patient. Finally, the patient is brought to the sitting position with the head hanging 30 degrees below the horizontal.
Again, let me redo this. So first you start off with the Dix-Hallpike test, and then you turn the head towards the unaffected side, the normal side.
The initial part of the Epley's maneuver is the same as Dix-Hallpike maneuver. The patient's head turned 45 degrees towards the affected side, and patient brought to the supine position with the head hanging 20 degrees. The patient's eyes are observed for nystagmus, and we wait for the nystagmus to stop. After stopping of the nystagmus, we wait for a further 30 seconds, and the patient's head is turned 90 degrees towards the opposite side. We again observe for nystagmus and wait for the nystagmus to stop, after which the patient's head is turned a further 90 degrees towards the unaffected side along with the body of the patient. Finally, the patient is brought to the sitting position with the head hanging 30 degrees below the horizontal.
Now, this is one of the most effective, procedures that you can do in the outpatient, and you will have instant relief of benign paroxysmal positional vertigo if your diagnosis is correct. The patient will immediately tell you, "I'm fine." That's it. As simple as all that. The only post procedure instruction that you give the patient is to tell them to avoid lying on this side, for a few days, maybe a week or 10 days. Tell them to lie straight or to the opposite side, but not towards that side, and the head slightly elevated. But and then to avoid bending down too much. So these are all simple instructions that you can give them after the procedure. But they need no medication, absolute no medication. Believe me, you've done a good please. This patient is fine. They can go back and get back to their normal routine straight away. They'll be so grateful to you. They will, never forget your help. There's something which, really endears you to your patient, and it's something which anybody can do in their clinic. It is absolutely safe, and you have instantaneous gratification from the patient. Of course, the next peripheral vertigo that we need to talk about is Meniere's disease. It's a very common cause of peripheral vertigo after BPPV. You have the classical otological symptoms. That is, the patient will have the feeling of ear blockage, hearing loss, tinnitus, which could be roaring or loud tinnitus. And then you have this vertigo, which lasts for a few minutes to a few hours. So this is a very classical presentation, this syndrome of these four symptoms. That is a ear blockage, tinnitus, hearing loss, and nystagmus with vertigo. The management in acute phase, of course, you put them on labyrinthine sedatives like prochlorperazine, but the long-term management is all about sodium. You want to give them a low salt diet, salt restricted diet, put them on diuretics for a short period. And in the beta histine, of course, is a vasodilator, which is very helpful in Meniere's particularly. And in a, of course, very acute stage, along with labyrinthine sedatives, steroids are also given sometimes. And avoid cats, that is caffeine, alcohol, and stress and tension, and salt. The vestibular suppressants for acute vertigo, particularly in conditions like Meniere's, we have three major choices basically: prochlorperazine, cinnarizine, and dimenhydrinate. Most of us prefer prochlorperazine because it's much quicker in action, and the vertigo recurrence is far less compared to the others, and is very, very effective in nausea control as well as in controlling vomiting. And it's also an anxiolytic. So which patients, you don't have to give a separate anxiolytic like diazepam or something. This itself will also take care of the anxiety, which is a very, very important component of these patients. Cinnarizine also is helpful. It takes a little longer time for it to manifest, and it's not you have to combine it with a separate anxiolytic agent. Dimenhydrinate, it takes very variable in each individual. Nausea control happens very effectively with that, but it's again not a very good anxiolytic. So basically, for Meniere's disease, we give beta histine, salt restriction, vestibular rehabilitation therapy, and surgery. Uh, these are the exercises for vestibular rehabilitation therapy. It's very important in the long-term management of Meniere's disease. Hearing loss, we manage with hearing aids. Nowadays, we even do cochlear implants in these patients and so on. Vestibular neuronitis, as I said, is very uncommon cause of peripheral vestibular vertigo. The hallmark is they have a continuous vertigo for hours and days, 2 days, 3 days vertigo, which is continuous, associated with vomiting and so on. Patient is miserable. And the important thing is that there is no hearing loss at all, period. It's only vestibular. There is no cochlear involvement at all. But the important thing is to differentiate it from a brainstem stroke because, as I said, they're almost twins in presentation. And then you have to do the Hinds plus test, and you have an abnormal head impulse, you have unidirectional nystagmus, no skew, and no hearing loss, and this tells you it is a peripheral lesion vestibular. If you have a direction change in nystagmus, a normal head impulse, and if there is a vertical skew, and then that would put you in a possibility of a central lesion. Vestibular neuronitis is self-limiting condition. Just give them antivertigo, labyrinthine sedatives like prochlorperazine for a few days, cinnarizine or dimenhydrinate if you prefer, and anxiolytics. If you're giving cinnarizine, you have to combine with a benzodiazepine. With prochlorperazine, you don't have to do that. And these patients will recover inevitably with just rest and recovery for 3-4 days. They'll be back to normal. And as I said, differential diagnosis is a brainstem lesion, especially a peripheral. You have to think about a vascular lesion like a lateral medullary syndrome or so on. Labyrinthitis is a condition where you have vertigo lasting for a few days, just like vestibular neuritis, but accompanied by hearing loss. That's the difference. So if there is vertigo and hearing loss, you're talking about labyrinthitis. If you only have vertigo without hearing loss, you're talking about vestibular neuritis. So this is the important difference. So post-operative vertigo is, you need to have a little word about it. It's one of the most violent vertigos that you can ever see. If I have done a stepidotomy in a patient, for example, or if I have done a cholestoma, major cholestoma surgery where labyrinth is involved, these patients post-operatively have violent vertigo, and they'll be throwing up all over the place. But invariably, it will be compensated, and within 3 to 4 days, they'll get back normal. And you just have to manage this 3 to 4 days with labyrinth and sedatives. And in this situation, clearly the drug of choice is prochlorperazine. So infections of the ear and temporal bone like viral labyrinthitis, herpes zoster oticus, bacterial labyrinthitis, acute otitis media, cholesteatoma, petrositis, skull-base osteomyelitis, which is actually an accompaniment of uncontrolled diabetes. So these are all causes of, this is an extensive cholesteatoma, which is destroyed almost entirely you can see the entire temporal bone is completely destroyed. Such a patient will have violent vertigo. And other autological conditions like autosclerosis, autotoxicity, and some rare situations. You don't have to worry about it too much. Central vestibular disorders, thankfully, are very uncommon. Only 10% of patients presenting with vertigo actually have central vestibular pathology, and most of them are in the posterior fossa and they're infratentorial. By almost certainly they will be in the posterior fossa and infratentorial, and they're mainly damaging the brainstem and the cerebellum. These patients have ataxia and their constant feeling of unsteadiness. Whole list of conditions, but most common of them, of course, are the cerebrovascular conditions like migraine and Wallenberg's. Migraine is the most common central cause of vertigo, and followed by brainstem, stroke and brainstem vascular disorders. Migraine is the most common cause, as I said, of episodic vertigo, central cause. And almost 10 to 20% of all patients with migraine will have vertigo episodes at some point or time. And it can be sometimes a major symptom or the only symptom of migraine in about 5 to 10% of patients. Usually, you have to fulfill the criteria for migraine, so recurrent vestibular symptoms, history of migraine, headaches. You should meet up with the International Classification for Headache Disorders criteria, ICHD criteria. And then there may be associated following migraine symptoms such as visual or photophobia, phonophobia, and so on. And basilar migraine is a central form of vertigo where the aura is from the brainstem. And they may have other symptoms, including headache, visual disturbances, but always it is temporary, it is a transient, and then patient will recover from it with no residual lesion. That's a hallmark of migraine. Management and antiemetics, prochlorperazine is particularly effective in acute migraine-induced vertigo, but you have to treat the other in case of headaches. You have to put them on analgesics, ergotamine, dihydroergotamine, and then triptans like sumatriptan and so on are very, very helpful in these patients. Prophylaxis, usually we give them anti-epileptic drugs like topiramate, beta blockers, calcium antagonists like flunarizine, amitriptyline, and so on. So you need to treat the acute phase and then treat the long-term management with prophylaxis. Vertebro-basilar insufficiency, believe me, is very, 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 very rare. Unfortunately, a lot of people will diagnose vertebro-basilar insufficiency just based on an X-ray cervical spine. If you are an Indian and you're over the age of 45, you'll be very rare indeed for you not to have cervical spondylitis. It's almost a racial feature for us. If you're 50 and above, take it from me, you will 100% have some changes in your cervical spines. So that is no diagnosis, or there's no reason to diagnose vertebral-basilar insufficiency. It is as ludicrous as saying that if you're right-handed individual, you will get headache. That's how silly it is. So true vertebral-basilar insufficiency is very, very rare. I probably have see one or two in a year. Even that I would be very surprised. Then strokes, majority are ischemic, and dizziness is common in posterior circulation ischemic symptoms. And the only hemorrhagic stroke commonly associated with vertigo or dizziness is cerebellar hemorrhage. So that's something that you always have to think about. So brainstem and cerebellar lesions, hemorrhage, particularly are known to present with dizziness or vertigo. And then lateral medullary syndrome is the so-called pica cerebral artery supply. That is basically the posterior infracerebral artery supplies the part of the brainstem and the cerebellum, and this is a part which is concerned with balance in a lot of patients. Classically, they'll have because of the involvement of the cerebellum, they'll have vertigo and spontaneous nystagmus. It may be direction changing, or it may be they may be having vertical nystagmus. They will have skew deviation, and they will have limb ataxia and facial hemianesthesia. So on the side of the lesion, you will have a facial loss of pain and temperature sensation. And on the contralateral side, you'll have a pain and temperature loss on the body. So face on this side and the body on the opposite side because of spinothalamic tract involvement. ICA or anterior infracerebral artery infarction is even more serious. It's mostly invariably fatal, and it is really a very, very serious condition. Vertebral artery dissection, very rare. I don't think you should worry too much about it. And cerebellar diseases, particularly cerebellar degenerations, second metastatic lesions, certain drugs, alcohol, of course, vitamin E deficiency. All these are not unknown, and you see them in neurological practice. Many senior neurologists will see them, and they can present with vertigo also. The brain tumor, which presents typically classically, is the posterior fossa brain tumor, cerebellopontine angle tumor. And vestibular schwannoma, interestingly, is a tumor which actually comes from the vestibular nerve. So you'd expect vertigo as a feature of it, but it's very, very rare. Vertigo is a very rare symptom in vestibular schwannoma. And the reason is that it's a very slow growing tumor, and there's plenty of time for compensation from the opposite side. Which is why vestibular schwannoma patients, very rarely present with vertigo. They will present with hearing loss due to compression on the cochlear nerve, but they very rarely will talk about vertigo in these patients. But other infratentorial brain tumors, particularly of the cerebellum, of the things like gliomas, meningiomas, medulloblastomas, and so on, the infratentorial brain tumors may present with vertigo in a lot of patients. As I said, vestibular schwannoma, very, very rare presentation of vertigo. I think you don't even have to think about it too often, but occasionally it may present. Suddenly, if it enlarges in size due to a hemorrhage or something, then these patients will present with vertigo. And otitic infections, abscess, extradural abscess, subdural abscess, they, especially involving the cerebellum, can cause vestibular symptoms. Multiple sclerosis, again, not very common in Indians, but it does happen. And these typically present with what is known as internuclear ophthalmoplegia. Asking the patient to look to the left side, you can see this eye is moving to the left, but the right is not moving. And this eye, which is not moving, will have nystagmus. So this is known as internuclear ophthalmoplegia. This patient has got a right-sided medial longitudinal fasciculus lesion. So this is a classical presentation of multiple sclerosis. In addition, they have intention tremors, and they have what is known as a Lermit sign. It's a very interesting sign. That is known as a barber's chair sign. The patient sitting, and suddenly, if you ask him to bring this head down, you'll have a shooting electricity kind of sensation going down his spine and into his limbs. So that is supposed to be a very reliable sign of multiple sclerosis. And MRI with flare will show the plaques. Right. And finally, vestibular seizures and cardiovascular causes like orthostatic hypotension. We talked about it earlier on, alpha blockers in elderly gentlemen with prostate problems and so on. So when do you have to emergently image a patient with acute vertigo? If a patient comes with acute vertigo, when do you say, I want an immediate scan? So anything to suggest a brainstem or cerebral symptom. If it is an asymmetric hearing loss, And there are stroke risk factors like diabetes, hypertension in this patient, acute onset with neck pain, direction changing nystagmus, and severe headache associated, or inability to stand or tendency to fall. All this should alert you. Immediately ask for imaging. And the image we want is a contrast enhanced MRI, which is a gold standard for acoustic neuroma, of course, and very small tumors also. But MRI angiogram also may show you vascular loops, and a CT and MRI of the inner ear. So eventually, in once the acute phase is over, then you can have time for all the other investigations like vestibular function tests, audiology, and so on. So vestibular tests and audiology tests are done not in the acute phase, but once the acute phase is tided over and the patient is fine. There's a whole lot of them. You don't have to worry about it. But remember, these investigations only come into play after you manage the acute vertigo and in the long term. So, in conclude, pharmacotherapy is the mainstay of treatment in managing acute vertigo, and prochlorperazine is a very good drug to use in these situations. And vertigo is multidisciplinary. To determine the etiology of vertigo is everything, and it will determine subsequent management. History and clinical examination are very, very important to differentiate a peripheral from a central vertigo. And imaging is mandatory in certain cases to confirm your diagnosis. So this is what I would like you to take home with you in management of acute vertigo. Hypertension during an acute vertiginous episode means nothing. It just means that the patient is anxious. So it is not a cause of the vertigo. And cervical vertigo is very, very rare. And please don't be saying, so, cervical osteoarthrosis with vertebral basilar insufficiency. That's a waste way of a vascular diagnosis. It's almost as saying that I don't know. And reassuring patients with acute vertigo is crucial in successful management. Thank you once again for this opportunity, and I will be more than happy to take your questions. Thank you.
So thank you, sir. Thanks a lot for such an excellent illustrative presentation, and I sincerely assure you that most of the people out there might have good, fruitful learning by attending your this particular session. So, sir, as you rightly pointed out about different causes of peripheral central vertigo, how to diagnose them and how to manage them in a acute phase, and then once the acute phase gets stabilized, you need to rule out the cause and treat the cause. So thanks, sir. And now we
Thank you.
would go for the questions. I will see the questions of the audiences. I also request the audiences to send questions. Any questions they want to get clarified from Professor Kameswaran can be type in the chat box and send to us. So, sir, first question is on vestibular rehabilitation, sir. How far vestibular rehabilitation exercise helpful in acute vertigo? This is from Dr. Kamla Kannan.
Yeah. It's not in acute vertigo, it's in chronic vertigo. In acute vertigo, you're only interested in managing the vertigo then and there. It's a question of a few days. So that is at that time the management is mainly pharmacological. You want to reassure the patient, you want to settle the vertigo, you want to give him labyrinthine sedatives, get over his acute symptoms like vomiting and so on, and give him relief. The long-term management is when the vestibular rehabilitation exercises come in. So, for example, take a patient with Meniere's. Now, this patient comes to you with severe acute exacerbation with vomiting and so on. You will then be treating him with labyrinthine sedatives. He gets over that in 3 days, 4 days later, he's fine, he's better. He comes for your first follow-up a week later, and there's no more vertigo or vomiting. But he's still very unsure of himself. He's very insecure. Now that's when the vestibular exercises take over. It's a long-term management.
Thank you, sir. Thanks for the response. Next question is, sir, pregnant woman during her first trimester vertigo, what would be the drug of choice? From Dr. Fatima Shaheen, Vellore.
Yeah. Yes, it depends on which kind of vertigo they are having. Now, if they are going to be having a very violent vertigo, and it is going to be causing very severe vomiting and so on, we generally like to avoid all labyrinthine sedatives in these patients. In fact, the vast majority of them are just given anxiolytics and rest, and then they settle down. But if it is persisting beyond a limit where the patient is severely vertiginous and so on, then you may be thinking about drugs which are going to be used, like cinnarizine, for example, or prochlorperazine. But we don't like it. We keep it as a very last resort in somebody who is uh, having a vestibular lesion in a patient with pregnancy. Just simple pregnancy-induced nausea and vomiting, they don't really don't need to think of any of these. Uh, you just have to reassure them, give them hydration, and ask them to rest, and they should be fine. Vestibular lesions in these patients have to be treated depending on the severity of the condition. But the general rule of avoiding all these drugs in pregnancy, especially in the first trimester, I think the important thing is just give them anxiolytics and rest, and invariably in 3 to 4 days' time, the compensation takes over. So you just have to manage them for the first few days.
Thank you, sir. Moving ahead with the next question, uh, Dr. Amit Kumar from Rosera has asked, "What is the cause of vomiting in vertigo?"
Very good question. See, the chemoreceptor trigger zone in the brainstem is very close to the vestibular nucleus. So we suspect that when you have a very violent vestibular nuclear stimulus, that is somebody who's having very severe peripheral lesion, the vestibular nucleus is stimulated on that side. And this electrical stimulus leaks to the chemoreceptor trigger zone just as next to it. In fact, there are a lot of interconnecting neurons between the two. And this triggers the chemoreceptor trigger zone, and that is why they have these vegetative symptoms. They can also develop bradycardia in some patients because the vagus nucleus also is next to them. So some of them may even develop bradycardia. But basically, the chemoreceptor trigger zone is just next door to the vestibular nucleus. And that is why a lot of them will have vegetative symptoms and vagal symptoms also in some of them.
Thanks, sir. Moving ahead with the next question. Question from Dr. Rameshwar Jaiswal from Ujjain. How to manage repeated frequent episodes of PPPV after 2 or 3 weeks treatment? Again, they present in a similar episode sometime. So if the patient comes with a recurrence of BPPV, sir, the doctor is asking how to manage those cases.
Again, a very good question. There are some people who are very prone for this, and you can actually teach them to do an EPIS at home themselves. You can actually do that. Many of them become smart enough that they will do it at home themselves and correct it themselves. And it's a very simple thing to do. Now, if there's very severe vertigo, positional vertigo, and it happens very often, then there are surgical options. We close off the posterior canal ampulla, and we can stop that. But that's very rare. It's an extremely rare situation. Such a person will probably be one in a million. So I don't think you should worry too much about it. But you need to know that there are surgical options. However, the usual thing is for these people to be taught to do their own EPIs at home, and they quite effectively do it.
Thank you, sir, and good response to this because home please is something which helps lot of patients, sir.
Yes,
So
a lot of
moving
them.
ahead with the next question, sir. A doctor has asked about Dr. Mohammad S. Khan from Kolkata. He has asked that should we suggest any lifestyle modification along with medication?
Absolutely. Particularly in migrainous vertigo, it's very common. In many years, of course, it's a diet, salt restricted diet, very important. In patients with migrainous vertigo, lifestyle modification is everything. I think it's even more important than medication, pharmacotherapy, because these are the characters who will be benefited most from lifestyle modification. The simple thing I tell them is lead a disciplined life, like a good army officer. Learn to get up on time, eat on time, sleep on time, get adequate sleep, rest, mental rest, develop hobbies, stress busters. So things like, you take up yoga, one may take up some hobby like reading or horse riding or medication. I mean, sorry, or meditation or something. So, level up stress busters. But above all, learn to lead a disciplined life with proper sleep and rest. Certain diet modifications, of course, we know that cheese, especially cottage cheese like paneer, can trigger in some people. Cocoa items like chocolates, excessive caffeine, can trigger in some people. So they have to be careful about all those things. But most of them would have recognized it themselves, and they'll instinctively avoid it. So you can tell them that red wine, for example, in some people can trigger migraine. So you have to be giving them ideas, but it's not the same rule for everybody. I mean, they have to work out their own strategies. They will know which is causing a problem for them and learn to avoid it instinctively.
Thank you, sir. Very nice response to this question, sir. Next question is from Dr. Uma Natraj from Mumbai. She asked about Epley's maneuver, that BPPV is managed by Epley's maneuver, but should we get it repeat, and how often should we do it?
No, you don't need to repeat it. If you've done one Epley's properly, it solves the problem. That's it. It's the end of the story. So, as somebody asked earlier, it can repeat again in some patients, and in that case, you can teach them to do it themselves. But if an efficiently done Epley's, once it's done, that's it. It solves the problem. Patient goes home a happy man, very grateful to you and indebted. So, you don't need to be repeating it. You just tell them after the procedure when they go home to avoid lying down on the side and extreme neck movements like bending down, picking up, or looking up and carrying things and so on. So that you avoid, but for a few days, maybe a week or 10 days. But generally speaking, and after an epilepsy, you don't need to do nothing at all.
Next question is also related to BPPV, sir, only that how to manage a elderly patient of recurrent BPPV attacks. This is from Dr. P.N. Jori, Bhopal.
Yeah, good question again. Some very elderly people, it may be difficult to do a please. You can try, teach them to do it themselves. We do. In fact, even in 70, 75-year-old people, we do a please. But if they have very severe neck problems or, say have very stiff neck or something like that, then you have to just depend on pharmacotherapy. We just give them labyrinthine sedatives for a few days and then allow them to, because it's self-limiting disease. Very rarely will a BPPV go beyond a couple of weeks. So it will self-limiting. And that period you have to manage them with symptomatic management.
Sir, moving ahead, next question. Now we are getting more and more question. And sir, I just want to compliment you that most of our audiences have mentioned excellent, very informative, very good.
Thank
So
you.
people
Thank you.
have enjoyed your presentation, sir, and they have learned a lot during this last 1 hour session of yours, sir. So thanks for that. So
Thank
moving ahead,
you.
the next question is, should I prescribe prochlorperazine in acute vertigo without nausea vomiting? This is from Manu Bazaar, Kolkata, sir.
If you have an acute vertigo without nausea or vomiting, it is bad news. There's no doubt about it because then the chances are very high it is central vertigo. Now, in that situation, the management is with the prochlorperazine or any other labyrinth therapy is not at all important. What is important is to emergently make the diagnosis out because this patient could be dying. He could be developing a stroke, a brainstem stroke, and he could be dying. So you really are there. The focus is not on controlling the vertigo, it's on finding out what's causing the vertigo. So if a severe vertigo, an acute vertigo patient does not have nausea or vomiting, something is seriously wrong. So, start thinking in terms of a brainstem lesion then.
Thank you, sir. Next question is from Mumbai, where question is the role of beta histine in acute vertigo.
Not much. Beta histine is a drug for chronic vertigo. It's not for acute vertigo. Acute vertigo, you need labyrinthine sedatives. Beta histine is a drug which actually helps in labyrinthine compensation. So that's not a drug of choice for an acute vertigo. Acute vertigo, you are thinking about suppressing the labyrinth so that you want to stop the vertigo. Beta histine is a drug which actually encourages the labyrinth to be compensated. So that's not going to be very helpful then. So basically, look at labyrinthine sedative in the acute phase. So beta chlorperazine, cinnarizine, dimenhydrinate. So these are the drugs which you are looking at.
Thank you, sir. Few more questions, sir. One question is on patient case study that migrainous vertigo patient, 50-year-old male with blood pressure of 90 by 70 is on flunarizine 10 milligram HS at night. So, what would be the further suggestions for his management?
I think gradually wean off the flunarizine if his vertigo is set, if his, my migraine vertigo settle down. So make the 10 into 5, and then make the 5 into alternate nights, and then twice a week, and then wean off. So basically, if your acute vertiginous episodes have stopped, then it's time for you to withdraw the flunarizine, and then teach them lifestyle manage modifications and management. That's all you need to do. Yeah.
Sir, one last question. Basically, it is on again prochlorperazine from Dr. Thomas Anthony Kochi. That why injection dose is higher than oral of prochlorperazine.
Yeah, actually, I'm not very sure about it, but I think it's about bioavailability, actually. And the injection is also, don't forget, is reserved for very acute episodes. Whereas the tablets are meant for, of course, now the mouth dissolving tablets are very helpful also in the acute period. But basically, the oral medication is meant once you got over the vomiting phase. So the vomiting phase is acute phase, and its symptoms are very violent. And 12.5 milligram injectable dose is the dose which actually helps to stop the vomiting. So that's why it is given.
So with this, sir, we end this question and answer session, and it was a nice session with you, sir, and you have responded all the questions very satisfactorily. And as expected, you have steal the show, and it met our expectations. And I hope people out there attending this particular webinar will definitely have fruitful learning, which they can use in their clinical practice, and which can improve the patient quality of life, which is the ultimate goal of doing these kind of webinars. So, sir, thanks for your excellent presentation, and thanks for sharing your knowledge and your experience with all of us. I would also like to express our sincere gratitude for giving us this opportunity to have you with us as a speaker, and always supported us and guided us on different kind of initiatives and projects that we do for therapy shaping in the therapy area of vertigo. Thanks for that, sir.
Thank you.
Uh,
Thank you so
I
much. Thank you.
also, yes, I also thanks all the live audiences who have joined us today. Just to tell you that we have close to more than 2,000 audiences who have joined us, sir, live during this last 1.5 hours. And so I thank each one of you, because today is Saturday evening, and you have came out of your hectic schedule and joined this event. So thank you for sparing time out of your schedule and being a part of this webinar. I sincerely hope that every one of you has learned one or the other learning which you can utilize in your clinical practice. We will definitely do these kind of initiatives in future also with people like Professor Kameswaran, the thought leaders. We will again bring some new thought leader in coming days. So do join us in future also. I also thanks our commercial and marketing colleague and sales colleague for putting up this great show, for giving us this opportunity to be a part of this event and to conduct this very smoothly. And last but not the least, I thanks our partner, the DocMode team, who has provided us this digital platform where we can run this program in a very efficient and smooth manner. So thank you all. And with this, we will end the show. And thank you. Thank you for
Thank,
joining. Thank you.
thank you. Thank you very much.
And goodbye to all. Bye, everyone.